to the Thyroid Stimulating Podcast. This podcast was created in partnership with the American Thyroid Association to discuss up-to-date diagnosis and management of a wide array of thyroid diseases. Today's episode shines a spotlight on a revolutionary approach to treating thyroid nodules, known as microwave ablation. This minimally invasive procedure has garnered significant attention in the medical community for its effectiveness, its efficiency, and the promising outcomes for patients with thyroid nodules. We're thrilled to have an esteemed guest with us today, Dr. Samer Nakhle, joining us from Las Vegas. He is the medical director of Palm Medical Group and the Endocrinology Fellowship Program Director of Sunrise Health in Las Vegas. He is at the forefront of employing innovative treatments for thyroid conditions and has a wealth of experience in using thermal ablation procedures, including both microwave ablation and radiofrequency ablation for the treatment of thyroid nodules. Throughout this episode, we'll dive into what microwave ablation entails, its mechanism, and why it stands out as the preferred method of managing thyroid nodules. We'll hear firsthand from Dr. Nakhle about his experience and insights into the procedure, the science behind it, and what patients can expect during and after treatment.
Thank you. I'm Dr. Nakhle.
Okay, so can you explain to us what microwave ablation is and how does it work to shrink thyroid nodules?
Microwave ablation work on the idea of thermal ablation. So from since 2000, we start thinking about using heat as the method to cause tissue death and eliminate nodule, and started for cancer treatment. So the microwave, it's a microwave generator that can get the microwave to the tissue through and the tip of the needle. So it's a needle, the tip of it generates electromagnetic wave. The electromagnetic wave causes the water to vibrate in the cell, so water oscillation in the tissue, and causes cellular damage using heat. But because of the oscillation, generate heat, the friction, and it generates temperature about 60 centigrade, 140 Fahrenheit in the tissue around it. So that's the principle of it. Wherever we put the needle, we can generate uniform heat spread from the tip of the needle into the tissue and causes tissue damage and necrosis.
Where was it first created, or the procedure invented?
Started in the you look at the first publication was talking about the generator. It was a big generator. It was in China. So in China, started there. The first publication about thyroid nodule treatment with the microwave was in 2005 from there. So right now, there's about 4 companies, 3 from China and 1 from Italy, that make those machines, make the generator. So the generator used to be a very big machine. Now it's portable. We can take it around, and it just generate microwave. And the idea is to transfer those waves to the needle, and the needle tip release it in the tissue wherever you put it in.
And how long have you been doing this procedure personally?
About now, we're going on year 2.
Okay. How effective is it in reducing symptoms associated with thyroid nodules?
So the microwave would generate the heat. So when we start doing microwave and we look at the old data, they're always about the nodule shrinkage. How much can we eliminate of the nodule? And we have enough data from publication over the last 15 years that showed after 1 year, the nodule shrink about 90%. But we have enough data from other thermal ablation that if you're able to shrink the nodule by 50%, you get rid of the symptoms. So 50% is enough to eliminate any symptom from compressive symptom of nodule. But with the microwave, and more about also personal experience, how much you're gonna move the needle and eliminate, how much tissue you can eliminate. We can eliminate about up to 90% on average after 1 year. So the symptom-wise, by eliminating 50%, you can get rid of this symptom. And if you look at the data, it showed about the study, all studies showed 95% symptom relief at 3 months.
Oh, great. So it works pretty fast overall. Not as fast as surgery, which would be immediate, but pretty fast in the first couple of months. So are there any risks or potential complications associated with microwave ablation?
Let's talk about the technique, the idea. So when we put the needle in the tissue that we want to eliminate, and it generates the microwave can spread through that tissue. So the microwave principle, if you can leave the needle in the same spot, it will generate heat very fast and spread and continue to spread till you stop it, or you move the needle to different spot. The complication happens when you end up spreading the heat outside the nodule. So when we treat benign nodules, our goal is not to eliminate every bit of tissue. So we're leaving the margin clear, and we're moving the needle around. We call it moving shot. You move the needle around, you hit all that tissue. Or if you leave it in the middle, just watch with the ultrasound so the heat does not spread out. So the damage is from heat getting out, treating the surrounding tissue. The main issue we worry about is the recurrent nerve for the vocal cord that run behind the thyroid. So we know anatomically where that nerve is sitting, and we can avoid it. So we avoid that triangle we call danger triangle. We don't treat that area. We treat the rest of the tissue. And if we're looking constantly with the ultrasound, we should avoid that. When you look at study complication, when we treat benign nodule, the recurrent nerve injury temporary was about less than 5 in 1,000, and permanent was rare. The complication we see about thermal ablation, we're all driven when we treat cancer, because with cancer treatment, you have to eliminate part of the normal tissue surrounding it, and the nerve could be there. But mainly it's nerve damage, recurrent nerve injury.
What about any risk of bleeding or hematoma or bruising?
So the bleeding in the nozzle is rare because the way the heat works, the way the microwave works, it coagulates the blood vessel. So one of the reasons why we prefer microwave, because we don't have an issue with blood vessel. It just make whatever blood vessel going through the nozzle coagulate and eliminate the blood flow into the nodule. So it coagulates all those blood vessels inside the nodule, and that's what we want to do. We want to not only damage the tissue, eliminate that nutrition coming through the artery and the vein, so we don't get. So the bleed is not in the nodule, is not part of the complication. The bruise is where you put the needle through the skin surrounding the nodule. That part of it could be because we're using 16 gauge or 17 gauge needle, and the bruising from putting the lidocaine around it. So that's one part. The other part, complication, worry about every time you introduce any foreign body in a needle, is infection, and it's beyond rare. The main complication is the discomfort and pain. So complication, we can put them into two categories. During the procedure complication, which is the pain, possible recurrent nerve injury, mainly pain, the discomfort can get people to get lightheaded and dizzy, vasovagal respond, nausea, those all during the procedure. With the microwave are less because the heat generate is not very strong to cause pain. So the pain I found out with using microwave is much less than other thermal ablation. Infection, you see it 1 in 1,000 is how you introduce the needle into the skin and bring in bacteria inside. Mainly that during the procedure. After the procedure, the pain, usually when the patient leave, if they have pain, that's what they have. That's the max, and it gets better within a couple of days, goes away. They feel a lump because the tissue, when you heat it, it shrinks, and it's now not soft anymore. It is solid tissue. The nodule ends up solid tissue. They feel a lump when they swallow for about 2 to 3 days, and that's it. Rest is, if there's recurrent nerve injury, it takes temporary, usually recovery between 1 week to 12 weeks. And if it's permanent, it would not recover after 12 weeks. But the max 12 weeks for temporary recovery.
So I know you briefly touched on this, but what are some advantages of microwave ablation over traditional surgery and over other thermal ablations such as RFA, which is the other main one?
Microwave versus surgery. I mean, surgery, it's hospital admission, anesthesia, OR cost, and the other risk come with the surgery is parathyroid damage or recurrent nerve injury. You're looking at the microwave procedures done outpatient in the office, not an OR room, semi-sterile. Just, I see the microwave the same as doing a thyroid biopsy in the office. It's a little bit bigger needle, but the rest is exactly the same. The same cleanliness, the same requirement in the room. We don't need anything extra. And as long the experience, whoever doing it, making sure that you keep an eye on the tip of the needle, because there where the heat gonna spread, and you don't have a parathyroid injury or bleed or anything that come with the surgery. The surgery still has the advantage of, if the very large nodule and going substernal, with the thermal ablation, we can't go very deep. So if very large nodule, we might need to do 2 or 3 treatment. After 1 treatment, it all shrink and go up, so we can address the lower part of it. So still surgery is superior in that. Surgery is if we have a nodule, right now with the requirement, we want to make sure the nodule is 100% benign before we treat. The requirement is 2 biopsy, but even if we have 2 biopsy, and we look at it with ultrasound, it does not have the feature not looking good, a lot of calcification, a lot of area of necrosis. Sometimes the biopsy, if you repeat, it might be negative. So those people, I would still go for surgery. So you still have, if you doubt that it's 100% benign, we're talking surgery. Substernal, if you're going to get rid of it, surgery. If it's bilateral, very large nodule, we're still going to go for surgery. Otherwise, we might need 2 or 3 treatment, because we cannot treat both sides at the same time. So treat one side at a time. So the number of treatment versus surgery, that's where the discussion going to be one-on-one with the patient. But definitely the cost, outpatient procedure versus inpatient, that compared to surgery. And from that, I can come back to who I believe microwave is good for. But I believe which thyroid nodule is good candidate for microwave ablation is nodule that will prove it's benign. Right now, the standard in the United States is that almost the same as indication for surgery. So it has to have symptoms, either difficulty swallowing, difficulty breathing, discomfort when they lie down, pain in the nodule area, or if we see the nodule, so that kind of part of it, if the nodule is visible, that is indication for treatment. Definitely one of the areas that's proven benefit is what you call toxic thyroid nodule, hyperactive nodule, because that's proven superior, cure it, it's effective, and the microwave effective there because we can eliminate the blood flow in it. So large nodule, we can see them with symptom and toxic nodule. The other group are thyroid cancer who are not candidates for surgery. So as of now, the thermal ablation use more of a palliative. So if they're not candidate surgery, we're treating If they have a recurrent that not candidate for surgery on lymph node, we're treating that. But the mainly is still the focus on benign nodule with symptoms.
I get asked this a lot. Is there a certain size that's too small or something that's too large for this procedure?
I'll start with too small. I mean, with too small, you can eliminate with the microwave, but the question, why are you doing that? You have to have a reason. If you prove it's growing and you're concerned about that, and the size, we're saying if there's a symptom from it, if the physician believes the symptom are driven by that nodule. On the other side, the medicine, we're doing all those biopsies now with the genetic testing. I think the future is going to be able to answer that by having what genetic mapping, what kind of mutation we have in the nodule to figure out this is going to grow. So maybe you should treat it at small size. But the big nodule, if it's big and going substernal, you can't reach the lower part of it to eliminate. It's still doable with a microwave, but you might need to do 2 treatments. I would start that with the patient. You might need more than one treatment, especially right now with the cost of cash pay most patients. They might elect to go for surgery at that if the nodule is very big. So the size is a big size might need more than one treatment and the cost.
So when you're discussing it with the patient, what do you tell the patient the recovery process will be like? I know you talked about pain. Leaving is probably going to be the most pain, and then the complications. But overall, how do you describe the recovery process for your patients?
So, when we started at the beginning, we used to tell them they have to bring somebody with them to drive home. Right now, we just the same as what we tell people when we do the biopsy. We're going to do the needle in. You're going to sit about half an hour in the office and at the room waiting. We check on you. If there's no bruises, no pain, you go home. And and people back to work the next day. So there's no downtime except after the procedure, just go home.
And then long-term, sorry. Oh, yeah. Long-term wise, I know you talked about, you could possibly very, very rarely have vocal cord issues, like voice issues. But are there any other long-term effects? Like, do these nodules grow back? Any symptoms delayed symptoms that they might get?
So that's the data from all those. There's now almost from the Chinese publications, almost 20,000 patients was treated, and a lot of them with about 2,000 with thyroid cancer. When you look at their data, the complication is going to happen after the procedure. After the procedure, that's what your long term. The regrowth rate is about 2 to 4%. So that's the regrowth rate. But they did not, that regrowth rate that came back with symptoms that you need to have treatment, there's no documentation about that. There's no data about that. But the size regrowth is about 2 to 4%. And that's why I believe eliminating the artery that's going into that nozzle are essential part of the treatment. And that's there where the microwave come in comparing to other thermal ablation. So when we're looking at the RFA can eliminate the same thing, 90% of the nodule. But with the technique, when we use microwave versus other technique, microwave can be used as what we call moving shot. You hit one spot and you move, like every time you hit an area about 1 centimeter, you move around till you address the whole nodule. And that's the technology we use with RFA. But the other part with the microwave, you can still leave it in one spot and give it a minute, and it will give you about almost 2 centimeters of burn area. Everything in that 2 centimeter blood flow, anything gonna get stopped. We cannot do that with the RFA because you get charring around it. The RFA needle itself get hot, so it cannot do fixed approach. So that one thing that the microwave combined, it can do fixed approach versus spreading, and we don't have to worry about what's called heat sink. when you have a blood vessel going next to the heated area, that blood flow is like water flow. It just takes the heat away, so the tissue does not get burned. With microwave, that blood vessel get eliminated easily. So the eliminating the blood vessel is the one different. We don't have the heat sink, and it's faster procedure. So it takes us less than 10 minutes usually as a procedure. That's why I believe it's part of endocrine practice, part of outpatient practice. We schedule it. We give it about 45-minute block of the day. So a little bit longer than biopsy, but with the right setup in the practice, we do it, normal appointment.
Speaking of that, since you're a fellowship director, do you train your fellows in doing this procedure, or do you have them participate with you?
Yeah, I mean, I think this is going to be that's what we wanted to be part of the endocrine practice. My fellow go with me and assist me with the procedure, definitely. And because we're doing that, now we got better on teaching them when to do the biopsy, because sometimes I feel the biopsy is more difficult than the microwave, because microwave needle is much bigger, 17 gauge needle versus the biopsy 25. So it's very easy to see the microwave needle, but we know right now that when we did them how to do the biopsy, we want them to see the whole needle. So we do always federal approach. They have to see the whole needle. They have to see the tip of the needle always, because that's what you're going to do with the microwave. So if you're good doing the biopsy and you are good in tracking the tip of the needle, doing the microwave procedure should be very easy and simple for you to transition from biopsy to that. The other thing is, with the microwave, we need to do the lidocaine injection. We don't need that much lidocaine. We usually use about 3 cc of lidocaine in around the thyroid capsule. You put it in and you see it spreading. So that also, we learn from that. So we let the fellow do it when they do the biopsy. So then by the time they finish, if they're good with the biopsy, it's very easy transition to thermal ablation.
If you didn't learn this in fellowship, what resources would you suggest for someone who's interested in learning this procedure and incorporating it into their practice?
The NASAWA, which North American Endocrine Interventional Endocrinologists, North American Interventional Endocrinologists, the ATA, the American Thyroid Association, NASA, they're all have resource to learn it. But I found out the best way is there's now about 7 companies who do thermal ablation, 4 companies with microwave. If you contact them, they will come to you. They will take you to places where they're doing the thermal, and you can see it, learn how to do it, and they will help you to start.
Oh, great. And then I just wanted to end on what ongoing research or advancements are being made using microwave ablation. I think you briefly talked about cancer, but where is this going in the future? Where do you think it's going in the future?
When you look at other countries like South Korea and China and Italy, where they've been doing this for now, thermal ablation for more than 20 years, they're other than benign nodule, thyroid cancer, they use it as the primary approach instead of surgery right now. So from thyroid, and they use it for hyperthyroidism treatment. So I believe the next step in the United States, once we have enough study, going to be the thyroid cancer, how to approach that. And I believe with the advance of our molecular testing and genetic testing and identifying how aggressive that cancer, we're going to start picking up who's going to go through thermal ablation versus surgery. That's one part. But the interesting part to me is, for over the long run, is doing more than the thyroid cancer and the thyroid nodules, is addressing the Graves' disease or Hashimoto thyroiditis. Because you have enough study about Hashimoto thyroiditis, doing the surgery, eliminate your antibody. Is there another method to eliminate the antibody? But as of now, I'm not aware of anything in terms of microwave study going on in the United States. There's nothing yet.
To wrap up today's insightful discussion on microwave ablation for the treatment of thyroid nodules, we've covered the basics of how this innovative technique works, the benefits this technique offers compared to surgery and other ablative techniques, including radiofrequency ablation, and we've covered what patients can expect during and after the procedure. We hope this episode has illuminated some of the cutting-edge advancements in thyroid care, and perhaps has answered some of your questions about this treatment method. Thank you again for joining us on today's episode of the Thyroid Stimulating Podcast. Stay tuned for our next episode, where we will be diving into the world of checkpoint inhibitors used in cancer care treatment and their impact on the thyroid gland.
Thank you very much.